Good afternoon, students. Today we are going to have a short lecture on acute pyelonephritis. The topic comes under the competency number 28.10. Introduction. It is the most common disease of the kidney. Pyelonephritis is defined as inflammation affecting the tubules, interstitium and renal pelvis. It occurs in two forms, acute pyelonephritis and the other one is the chronic pyelonephritis. Acute pyelonephritis is caused by the bacterial infection and it is associated with urinary tract infection. Whereas in case of chronic pyelonephritis, obstruction and vesico-urethral reflex plays a major role. Coming to the pathogenesis, more than 85% of the urinary tract infection are caused by gram-negative bacilli. The most common one is the E. coli, followed by Proteus, Klebsiella and Enterobacter. Streptococcus faecalis, Staphylococcus and every other bacterial and fungal agents also cause lower urinary tract and renal infection. Mycobacterial and fungal organisms also cause pyelonephritis, which includes caseating and non-caseating granulomatous inflammation of the kidney. Whereas in case of immunocompromised patient, particularly those with transplanted organs, viruses such as polyomavirus, cytomegalovirus and adenovirus cause renal infection. There are two routes by which bacteria can reach the kidney. Through the bloodstream, that is known as the hematogenous spread, and from the lower urinary tract, that is known as the ascending infection. Coming to the hematogenous route, it is a less common route. It results from seedling of the kidney by bacteria from distant foci in the course of septicemia or localized infections such as infective endocarditis. Most likely to occur in the presence of urethral obstruction and in debilitated patient. Ascending infection, it is the most common cause for clinical pyelonephritis. The first step is the colonization of the distal urethral and introitus in case of female by coliform bacteria. From urethral to the bladder, the organism gain entrance during urethral catheterization or other instruments. In the absence of instrumentation, urinary infections are much more common in females because of shorter urethra. The other conditions include urinary tract obstruction and stasis of urine. Normally, organisms introduced in the bladder are cleared by the continual voiding and antibacterial properties. In case of urinary tract obstruction, which results in the incomplete emptying and residual urine. The presence of stasis, bacteria gets introduced into the bladder and can multiply. Urinary tract obstruction occurs in case of benign prostatic hypertrophy, calculi, tumor, neurogenic bladder dysfunction, which is caused by diabetic and spinal cord injury. Vesico-urethral reflex. The normal urethral insertion of the bladder is a one-way valve that prevents retrograde flow of urine. Incompetence of the vesico-urethral valve allows bacteria to ascend the urethra into the renal pelvis. Reflex is most often due to the congenital absence or shortening of the intravesical portion of the urethra. Acquired vesico-urethral reflex in adults can result from the persistent bladder atony, which is caused by spinal cord injury. Intrarenal reflex. Vesico-urethral reflex afford a mechanism to propel infected bladder urine and deep into the renal parenchyma through open ducts at the tips of the papillae. It is seen most commonly in upper and lower poles of the kidney, where the papillae tends to have flattened or concave tips rather than convex tips. This is the diagrammatic representation of what I have explained you already. The definition of acute pyelonephritis is the suppurative inflammation of the kidney which is caused by the bacterial and sometimes viral, which can reach the kidney by hematogenous spread or more common through the ureter in association with vesico-urethral reflex. The hallmarks of acute pyelonephritis are patchy interstitial suppurative inflammation, intratubular aggregates of neutrophils, neutrophilic tubulitis and tubular injury. The suppuration may occur as discrete focal abscesses or large wedge-shaped areas which can involve one or both kidneys. In early stages, the neutrophilic infiltration is limited to the tubules. Later, the infection can extend to the interstitium and produces abscesses that destroy the involved tubules. Clinical features. It is often associated with the following conditions such as urinary tract obstruction, instrumentation, especially catheterization, vesico-urethral reflex, pre-existing renal lesions such as intrarenal scarring and obstruction, diabetes, immunosuppression and immunodeficiency. The clinical features which includes the sudden onset of pain at costovertebral angle, fever and malaise, dysuria, frequency and urgency. The urine contains many leukocytes which is derived from the inflammatory infiltration. The findings of leukocyte cast, typically rich in neutrophils, indicates renal involvement. The diagnosis of infection is established by quantitative urine culture. Uncomplicated acute pyelonephritis follows a benign course, and the symptoms disappear within a few days after institution of appropriate antibiotic therapy. This is the pus cast to the urinary sediment. A viral pathogen causing pyelonephritis in kidney allograft is polyomavirus. The polyomavirus nephropathy shows the infection of the tubular epithelial cell nuclei leading to nuclear enlargement and intranuclear inclusion. Interstitial inflammatory infiltrate is also present. Coming to the gross finding of the pyelonephritis, the kidneys are swollen and enlarged. The cortical surface shows grayish white areas of inflammation and abscess formation. Coming to the microscopic findings, acute pyelonephritis is marked by the neutrophilic exudates within the tubules and interstitial inflammation. There are three complications of acute pyelonephritis. One is the papillary necrosis, next one is the pyonephrosis and perinephric abscess. Coming to papillary necrosis, which is more common in case of diabetic, sickle cell disease and in those with urinary tract obstruction, which is bilateral and it can be unilateral also. It affects one or all of the pyramids of the kidney. This is the papillary necrosis. The arrow marks indicates the areas of pale grey hemorrhage and necrosis which involve the papillae. The second complication is pyonephrosis, which is seen in total or almost complete obstruction. The suppurative exudate is unable to drain and fills the renal pelvis, calyces and ureter with pus. Perinephric abscess. Extension of suppurative inflammation through the renal capsule into the perinephric tissue. After the acute phase of pyelonephritis, healing occurs. The neutrophilic infiltrate is replaced by macrophages, lymphocytes and plasma cells. The inflammatory foci are replaced by irregular scars that can be seen on the cortical surface as fibrous depression. Such scars are characterized microscopically by tubular atrophy, interstitial fibrosis and lymphocytic infiltrate.